Hello, hello, everyone. Welcome to Wednesday, July 27th, Lunch and Learn. So Liz and I are always here every Wednesday, except the second Wednesday, that's Research Roundtable, but to do Ask the Experts, where you can ask us questions, we answer them, super excited. But once a month, we always do a Lunch and Learn, and that's where we really pick a topic that we hear from the community. A lot of people will be submitting it through iocdf.org/peace of mind. And these are topics that you want us to dive deeper into. And so I'm going to let Liz introduce today's Lunch and Learn. She'll give you a little bit of background on that. So we just thank everybody always for giving us different topics. And, then on the back end, we are always finding different experts to jump on and really give more content and context about that topic. But before Liz introduces both our guests, obviously, as well as the title of the talk, we just always have a little bit of announcements, and that's what we want to let you know, that this live stream is educational and is not intended to replace therapy. So for treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online research directory at iocdf.org/find-help. Fun fact, that's how I found my therapist all those years ago. So it's definitely amazing to locate a trained clinician near you. The International OCD Foundation is not a crisis hotline. If you are in a crisis or you are ever fearing suicidal or unsafe, please go to your local emergency room or call 911 or the suicide prevention hotline at 800-273-8255. We want to create a safe space and be kind and respectful to everyone. So at the end of the day, we're all here to support one another. And note that this is being broadcast on several social media platforms and is being recorded. So definitely make sure that I always say this before we jump in. This is your live stream. Please ask questions, comments, interact with people in the chat. We are doing our best to build community. So the more that you participate, the more the community grows. All right, I'm going to pass it over to Liz McIngvale, who's going to tell you a little bit about the stream and our guests.
And we will hop in. Thanks, Chris. It's good to see you. And both Dr. Netherton and Roar, thank you for being here. And I will introduce y'all in just a second. But let's talk about what we're talking about today. So today we are going to talk about perinatal OCD and anxiety. And when we talk about perinatal, we're talking about the perinatal period. So I'll let that be better defined later. But really, we're talking about pregnancy all the way through birth and after birth and the way it impacts mental health. Chris and I host this live stream all the time, as y'all know, and Chris, thank God for Chris, has been covering for me while I've been on leave. And one of the things he said to me a couple weeks ago is like, do you want me there or should I not be there? And I was like, no, you're going to be there, because here's why. There's two reasons. What we know about perinatal postpartum OCD is it doesn't impact just moms. It also impacts dads. And that's a really important thing for us to be talking about. I think a lot of times we know women are more likely to access mental health care than men. And there's a lot of stigma around the way OCD might kind of onset and increase, especially in the postpartum period for men. And I want us to talk about that. But second of all, I also wanted Chris here because one of the things I said is I was like, well, Chris, while these live streams are a lot of the live streams that we do are for us as consumers, individuals with OCD, they're also for professionals. And we know that we've got men, women, you name it, but everybody is going to treat some. If you're an OCD specialist, you are going to come across a patient in the perinatal period. And we want to make sure that you feel equipped to be able to work with them in the best way possible. So thank you for being here. I'm excited for today's live stream because I think that it has so much content, so much importance, so much value for really anyone. So while we'll talk about the perinatal period, a lot of what we're going to be talking about will be relevant across your lifespan as well. So as always, please say hi, let us know where you're joining from. And if you have any questions in particular today about OCD, anxiety during the perinatal period, please make sure you post them in the comment box and we will answer them as we go. So I want to introduce both of my guests who I've worked with across, I want to say like for years, but I don't know that it's been decades, but it feels like a long time. But I've certainly worked with them and we've been on different panels and we certainly have crossed paths in our career around what we do. And so we are so excited to have both of these amazing experts. The first is Dr. Jessica Roar. Dr. Roar is a board certified clinical psychologist with an additional certification in perinatal mental health. She's the director of the Women's Mental Health in the Department of Psychiatry and Behavioral Health and is committed to clinical and research efforts dedicated to the improvement of mental health, especially for moms and women. Dr. Roar is engaged in research and advocacy efforts that directly relate to new clinical interventions that are accessible and effective. She received her PhD in clinical psychology and completed her internship and postdoc at the VA right here in Houston, where I did as well. Thank you so much for joining us, Dr. Roar. We are so excited to have you today.
Thank you, guys. I'm honored to be here.
And the next is Dr. Netherton. So Dr. Netherton completed her undergraduate education at the University of Texas in Austin, at the medical school at the in medical school at the University of Texas at Houston, McGovern Medical School, and residency at Baylor College of Medicine. She serves as the regional medical director and director of MindPath Women's Mental Health Care in Texas. Dr. Netherton is going to be joining us and talking a lot today about medication during the perinatal period and how you navigate the psychiatric side, where Dr. Rohr will talk more about psychology and behavioral health. But of course, we all have input across the board. But Dr. Netherton, thank you for joining us. We're so excited to have you as well.
Thrilled to be here. Thank you.
Are you all Texas people?
Yes, Chris. So we just need you here. But
I know I need to go there. Actually, we've been chatting with the lead and national advocates about meeting up, and I keep saying, no, come here. It's like 70. It's chill. I'm gonna melt if I come to you. But I didn't realize those were Texas people.
Somehow we all, like last night on our text thread, we all pitched Houston, and everyone was like, "Is Liz okay with it?" And I was like, "I'm okay with it, but like, do you want to come to 110-degree heat?" Like, I'm a little confused. Most Texans escape Texas in the summer. But yeah, Chris, come down. We're excited. So yes, we are all from Texas, which is awesome. For those of us that are Texas residents, there's so much perinatal work happening, which is great. So let's start with a definition. So Dr. Rohr, if you want to start with just kind of defining first of all, what do we consider the perinatal period? And I think what's really important is for us to talk about what are normal things to expect in the perinatal period, but then when might there be signs of anxiety or OCD that need to actually be addressed or diagnosed?
That's a great question. And I love, starting with that because there are some normal changes that happen during the perinatal period. So we typically think of the perinatal period starting with pregnancy, and peri means around, right? So pregnancy through childbirth into postpartum. Typically that's up to a year postpartum, and then you're no longer considered postpartum. And Dr. Netherton and I talk all the time about how, and then you're supposed to have magically figured it all out, but that's not usually how it works. There are a lot of what are considered kind of normative experiences through pregnancy and postpartum. And one that's coming to mind immediately is sleep deprivation. And this is, we've talked a lot about how do we start to understand the difference between normal sleep deprivation and disordered sleep deprivation. And this is the case for any kind of experiences that come when you have these waves of hormones throughout your body. Somebody was talking earlier about having no issues. I think, Chris, it was you talking about people having no issues at all during pregnancy and then spiking postpartum. And there are these massive hormonal shifts that you have during pregnancy and then this immediate, drop in hormones postpartum. Women respond differently to these hormonal shifts. And sometimes for many women, we're not used to or comfortable kind of paying attention to those hormonal shifts and understanding what those mean for us. And so sometimes in pregnancy, that's the first time you're really confronted with those changes. There are certain anxieties that come during pregnancy and postpartum. They're very natural and normal, and in a lot of cases adaptive. You are all of a sudden in charge of a new baby. And I was listening to a podcast on postpartum OCD today, just to kind of brush up. And I loved the way she was talking about it. And she said the stakes are really high with a new baby. And this makes some of these anxieties that maybe are a little easier to dismiss, a little easier to not find so significant when it's just you. It makes them much harder to kind of treat in the same way. You're supposed to make sure your baby is fed. You're supposed to make sure they're safe. There are these anxieties that are pretty normal, and intrusive thoughts, as we know, are very normal. Most people experience intrusive thoughts. It's when we have difficulty kind of dismissing them as non-significant. That's when we can start to get into trouble. And then when we start giving into them, avoiding things because of those intrusive thoughts, giving up certain tasks, and then, of course, kind of checking and getting into some compensatory behaviors to manage those intrusive thoughts. That's when we're going to start to look at that as being more disordered rather than kind of normal experiences.
Yeah, I'm always curious, Jessica, maybe you have an answer for this, is like, we often see OCD coming for a lot of people as they're going through kind of like starting the puberty process. So 8 to 13, and then after puberty, kind of like that 18 to 21. And then I think, the third period that we hear so much about people developing really severe OCD symptoms is during the perinatal process because of what you just said, like that hormonal shift. Is there a lot of research going on in that world? And obviously we can't, talk about causation, but can we at least start to infer that there's a correlation between hormonal changes and the development of severe OCD symptoms?
I'm smiling, but just this is Elizabeth and I talk about this a lot in terms of the need to shift our understanding of these experiences away from being these discrete experiences that happen out of nowhere and more towards this lifespan approach to a woman's experience with her hormones.
So one of the things I had heard, or one of the stats I still use, it's probably a bit outdated, is that up to 20% of adults that are diagnosed with OCD are diagnosed in the perinatal or postpartum period. I don't know if that still stands true, Chris, but I think it's really important and a significant thing for us to think about, just because when we think about historically when is OCD diagnosed, it's actually diagnosed during these, oftentimes during kind of big life changes or hormonal shifts, right? So puberty, adolescence, big life changes, going off to college, getting a job, getting married, those sort of things. And then postpartum or perinatal period, it makes sense, right? That and that doesn't mean, I want to kind of back up for a second, right? That correlation is not causation, and to kind of say, like, having a baby didn't cause your OCD. You were born with OCD, right? Genetically, you were predisposed to having OCD. It's when was it going to be onset? And so we may not actually spend a ton of time in treatment focusing on the birth of the child, where if you're doing non-behavioral therapy interventions, they may spend a lot of time just talking about your childbirth and your pregnancy and that experience, where we're going to focus more on, okay, what symptoms do you have now? How can we address them, right? And I think that's important to talk about, is that does the actual pregnancy or childbirth, how relevant is that to the treatment once we actually are diagnosed at that point with postpartum anxiety, OCD, depression, whatever it may be?
I was also going to jump in there and highlight that when we think about diagnosis in the postpartum period and what brings that forward, there's both this huge stressor of having a baby. There's the hormonal shifts that are associated with having a baby, but there's also this acute period of severe sleep deprivation that I think we kind of take as a matter of course. Of course, moms don't get to sleep. Of course, new dads don't get to sleep. Of course, everybody's exhausted, but we don't talk as commonly about the mental health ramifications of that. We know they're huge. We know that we use, unfortunately, I say we, I mean kind of governments internationally use sleep deprivation as a form of torture. And it's because it makes people terribly depressed and anxious and exacerbates OCD. And can elicit symptoms of OCD in somebody that might not otherwise have them where they fully rested. And so the sleep deprivation piece can't be ignored in terms of precipitating factors.
Totally. No, I think that's really important. And so let's talk, and I say really important as I'm sleep deprived. I feel it. I was just actually texting my husband this morning. I'm like, you get to sleep through the night and I don't. And I'm exhausted. So, but we'll talk about a lot of that, and I'll share some of my stories in a little bit coming up. But before that, let's kind of bounce back to when would someone receive a diagnosis? So what might be some of the signs and symptoms that would actually warrant a clinical diagnosis? And can we differentiate, do y'all mind differentiating diagnostically between OCD, anxiety, or depression postpartum?
I can get started, and Dr. Ward, you jump in. So the most important feature that I think immediately grabs my attention is the mom in distress. And so typically when moms reach out to my office to make an appointment with me, there is a high level of distress there. It is not a kind of passing anxiety or intrusive thoughts that they're rapidly able to dismiss. Thoughts are persistent enough, severe enough, disturbing enough, causing functional impairment to a degree that mom reaches out for assistance, and I take that very seriously. And so when we think about diagnostic criteria for OCD, we're looking at symptoms that impair functioning, that are severe, that are bothersome, that are persistent. And so purely by virtue of mom being worried enough to reach out, that in my mind is a huge kind of a huge thing to attend to as a clinician. Often I hear moms worried, does this sound normal to you? Does this make sense to you? And their degree of distress in making that appointment with me with a psychiatrist during the postpartum period, again, is a huge factor. If you're distressed, it's worth reaching out about. It's worth talking to somebody about. I wouldn't dismiss that out of hand ever for anybody.
Could you explain that in a little bit more detail? Because I'm just thinking, like, the people that come to our office, right, whether they meet like specific criteria or not, we're going to say you're here, right? You're distressed enough that you're coming in, and so we want to treat it. But what about the folks that are at home? I have friends myself that are like, is this normal? Is this not normal? Like, I am sleep deprived. I'm feeling not like myself. Like, what would be some things that you would say would be some definite signs of like, you should reach out, or here's some symptoms that we absolutely want to address?
So if it is causing functional impairment, if it's getting in the way of your ability to take care of the baby, your ability to take care of yourself, if it's getting in the way of your ability to go about your day and to enjoy the baby and enjoy things that you might otherwise, if it's getting in the way of your ability to sleep at night, these would all be signs that you should reach out and talk with someone about it. It's really common for me to see moms with new onset OCD in the perinatal period who are waking up at night to check on the baby. And it is clearly impairing sleep above and beyond how sleep would be impaired even without OCD symptoms. And they're waking up to check and then getting up to check again and check again. And so again, the level of functional impairment, the way it's getting in the way of sleep, the way it's getting in the way of their ability to feel good about interactions with their baby, all would grab my attention.
I'm taking notes because I have some ideas and questions that are going to come up. Chris?
Yeah, I was going to throw in Summer's comment at 12:11, for moral support. But, if she becomes a mother, I wouldn't be surprised if I did. If somebody's already showing OCD symptoms, and, what I was just curious maybe about percentage, like, what's the likelihood of somebody who has OCD and then goes through the perinatal period? Is there statistics that we have yet, or is there not enough research that we don't have that answer yet about like how likely it is for someone to start developing, like, whether it's postpartum symptoms or just an exacerbation in symptoms during the perinatal period?
I have not seen numbers on that, but would love to. I don't think there's near enough research on new onset versus women who have OCD prior.
So the general prevalence of OCD, I've seen between 2 and 9% of people who have. Some of that's not strictly new onset, but the recurrence rates, I've seen 25 up to 75% recurrence of previously diagnosed OCD in the postpartum period. So it is a highly, so the prevalence rates at baseline are higher than the prevalence in the general population of OCD in the perinatal and postpartum period. But yeah, the recurrence rates are quite high.
Well, it's funny because Liz and I always talk about how we learn from these streams, and I just learned that, right? Like, this is definitely something that needs to have more focus, because I know that it's such a worry. I mean, Liz talked about it when she was our keynote for OCD SoCal. I think a lot of women and men as well, as the supporters, but I think a lot of women have that fear about getting pregnant. I think a big one I hear always is like, I'm going to pass the OCD down. But the bigger one that I hear is like, is my OCD going to get worse? Can I still be on my medication? So I think that there's a lot of fear there.
Yeah. And that's, I started to interrupt you because I got so excited about it, but
it's okay.
This is absolutely why I love the opportunities to do this and raise just kind of general mental health literacy, not just for ourselves, but for our loved ones and our friends. The prevalence of anxiety disorders is higher than the prevalence of postpartum depression. We're seeing more like 30 to 35% for anxiety disorders. And as y'all probably know, a lot of the research on anxiety disorders up to probably the past 5 or 10 years has just sort of folded in OCD. So it's kind of newer that they're starting to really look at that separately. But all most people know is postpartum depression. And the assessment that you generally get at the pediatrician after is for postpartum depression. Although Elizabeth and I also talk about it's really more of a measure of distress, but most practitioners don't know about postpartum OCD, anxiety, PTSD. I saw a recent paper that said that in a study of perinatal practitioners, 70% of them didn't identify OCD symptoms in like a little vignette. And so there is this very important piece of kind of knowledge and advocacy that comes along with these disorders that have likely, I mean, they've been around for centuries. This is not a new issue, but it is new that we're identifying and building advocacy efforts.
You know, and it's interesting because here I am in the mental health field. I've had OCD since I was 12, right? And so I remember when I got, when I was about to say when I got diagnosed with Olivia. Well, hello. when I was pregnant with Olivia, my first, I was super anxious about what postpartum period was going to be like for me. And I remember even my mom was like, do you have your support team set up? Like, what's the plan? And I was really appreciative that I felt like I had this like super proactive plan of like my clinician, my provider had a good talk with my husband of like, here's some things to look for. And if I start to do these things, like this is when I want you to step up and not. But two things kind of shocked me. So the first thing that shocked me that I want to talk a little bit about was I feel like I was over-prepared for OCD symptoms and underprepared for anxiety and depression. So what happened is I feel like I had my team of like, okay, like I'm probably going to have sexual intrusive thoughts. I might have harm thoughts, whatever. But like, I knew how to deal with all that. I had that ready. But what I wasn't prepared for was kind of the general heightened anxiety and depression that just kind of can not just happen, but that can ebb and flow right during this perinatal period. And I feel even as myself as a mental health clinician that I was a little bit like confused of, okay, so is this normal? Do I need to seek treatment for this? And I don't know if you ever experienced this with your patients. I didn't know how to explain it. Like, I remember kind of feeling stuck of like, I just feel a little off, or like, I don't feel like myself. And then it's like, well, so are you bonding with your baby? And you're like, well, I don't know. Like I love my baby, but like, maybe I'm not bonding. I'm not really sure. And I actually remember telling my husband, I remember saying to Matt at one point, you know, I feel like I'm not bonding with Olivia the way I'm supposed to be. And I'm like struggling with it. And I remember feeling really vulnerable, telling him and like kind of scared to tell him that, hey, I feel like I'm not bonding the way I'm supposed to be. And his response, God love him, was, no, that's not true. You love her. And I was like, oh, okay, right. And so what happened automatically, like I got quiet and I was just like, okay. And because it was clear that he wasn't understanding what I was trying to say. And it was like, yeah, I do love her. I'm not saying I don't love her, but like, I am not bonding the way I feel like I should be bonding. And granted, in retrospect, our daughter had a dairy allergy and reflux. And like, it was very hard to bond. It was a very difficult time for us those first 3 months. But at the same time, how can we, like, I guess, so two questions. Number one, any advice for like how to communicate with your providers, what you're feeling, even if you don't necessarily know what you're feeling? And then the second question is, how do you communicate with loved ones? And what would healthy support from them look like in this period? Because a lot of our viewers are family members, and I don't always know how to tell them how to support someone they love who's going through this period.
I'll jump in and then I want to hear what Elizabeth has to say too. But I had postpartum depression with my first, and I had such a similar experience of how do I know that this isn't just motherhood is hard. And that's what, the doctors would say. And I remember I was Googling postpartum depression. I remember I found a website that instead of the typical kind of symptom-based inventory, it was more like a list of cognitions that people with depression have compared to, and of course, these things are not black and white, right? It's not kind of a one-to-one, but it was more cognitions like my baby would be better with a different mother. I don't feel like I was the right choice for this. This was like these cognitions that were really kind of stuck for me at the time. And that really, I was like, oh, so I'm actually not, this isn't just, it's hard. It's too far. And I think that there is a part of this that is actually going to be more about how do we activate social support and bigger support systems early on, rather than depending on our OBs and whoever to be able to navigate that. Because I don't think that they will be able to, and I don't think we should expect that of them. But we can talk to our friends, find these forums online, have these kind of experiences where you go on and you say, I'm having these thoughts. Is that, what did you, oh, well, I had that and it turned out it was depression, or I had that, but it went away after I stopped breastfeeding, or whatever. But being able to kind of have that village built so you can bounce those ideas off of each other. And then you sort of take that education to the OB or whoever you're working with and say, I think this is what's going on. Yeah. Elizabeth, what do you?
So I had a couple of thoughts about that. I think I'm remembering similarly. I trained with Dr. Lucy Puryear, who is a renowned perinatal psychiatrist. She is the best. And she has 4 little ones herself. When I was training with her, I was pregnant with my second and had my second. And I remember her asking, "Are you enjoying this? Are you just loving this?" And thinking, "What? Is this enjoyable?" And I think that in and of itself, that idea of are you able to enjoy things? Are you able to enjoy the baby is a powerful question. It is, again, not a one-to-one correlation. It is not that every moment with a new baby is enjoyable. It isn't. It is not that struggling to enjoy things means necessarily that you have depression. But I do see that as a pretty a pretty helpful distinction to make, where moms that I see who are struggling across the board with depression, with anxiety, with OCD, are really struggling to enjoy things that moms who are not having those same symptoms are able to enjoy much easier. When you asked about how to talk about providers or how to talk about this experience with providers, one of the things that came to mind for me is the importance of an ongoing relationship with a provider. If that's with your therapist, with a psychiatrist, getting to know them prior to pregnancy, ideally. Best case scenario, if there are things that you're worried about, establishing care before getting pregnant, following with them periodically throughout pregnancy and the postpartum period, so that you have a relationship to draw on and they know you well. When I'm seeing patients that I know well, I can tell that something is shifting when they click on a call and I see their face. And I think most of us as therapists have this experience. We can tell when our patients are feeling well and when they're not. Even before we start to talk about what their actual experience is and what their symptoms are. And I think it gives you a much more kind of a much better platform to start to share what's in your mind or what you're worried about or what your thoughts are than seeing somebody for just the first time, trying to put words to it. And especially knowing some of the constraints of modern medicine and accessing providers. I know some people have the experience of going to a doctor's office and the doctor's like, okay, what are the symptoms? In and out. What's going on? Tell me now. We've only got so much time, and that can be terrifying to then try to put words to how you're feeling and try to give them the information that they might need to be helpful. So the more that can be predicated on a relationship with them, I think the better.
So I guess one of the questions I have though is like, I think it's great we're talking about what do you look for, when do you seek treatment, all of that. But I guess one of the things I'm wondering is like, what can you expect as an outcome from treatment, right? So like what I'm learning when you just said that question, it hit home to me candidly. Dr. Netherton is like, are you happy? Are you enjoying the experience? And I'm kind of like, I'm not so sure, like I love both of my kids, but it's a transition, right? And I've learned like, so I'm somebody that I feel like I bond more over time, right? And like the more interactive, that like suits me better. Some people love the newborn stage. And for me, I'm like, yeah, like I love the cuddles, but at the same time, like the interaction isn't there and it doesn't feel as reciprocal. But like, how can you also, I find myself struggling. I wrote down some notes that I wanted to talk about, but I find myself struggling a lot with guilt, like parent guilt, and giving myself self-compassion, and then also like what's normal and what isn't. So this is my second baby, and she's 6 weeks postpartum, and I find that she's so easy compared to my first. And so I will like feed her, burp her, whatever, and then we'll put her down for her nap. And so you can be present with the 15-month-old, which I have to be because she's wild and crazy. And then I feel guilt of like, oh, I'm like missing time with this other babe, with our newborn, and should I be doing this and should I not? And then you don't know what to do. And there's this piece where it's genuine. Like my husband and I were like, yeah, like there's a piece where like it is different having 2 versus 1, right? Like your time has to get split and like your ability to be there. But then there's also this piece of like, how do you not let guilt eat away at you? One of the things I was struggling with this morning is, so I woke up, and before I was coming into the office, I could have gone for like a small walk. And I really need to, like I want to, it's important to me, and I've made zero time to do it. But then it was like, okay, the baby's getting up. I could instead like spend more time with her. And that was the choice. But it really wasn't a choice for me, candidly. It was more of like, oh, I feel like that's what I'm supposed to be doing versus taking care of myself. And I am feeling the impact pretty significantly right now of no self-care, of like, I'm making no time for myself. Can you talk a little bit about just how moms, like how important is it to engage in self-care, to also engage in self-compassion, and how do you address the guilt and the anxiety that you feel when you make these choices for yourself at the expense sometimes of spending time with your kids?
Absolutely. And let me back up for just a second and say, I didn't mean to give the impression of kind of it's if you are doing well, you are kind of always enjoying things, because I think,
Yeah.
again, any of us know that that's not the case. And there is so much variability among women in times in children's lives that we tend to enjoy more. Dr. Rohr and I talk about this all the time too. Again, kind of some of us do enjoy infant stages more. Some of us enjoy toddlerhood more. I'm not sure who those moms are, but I know there are some that enjoy toddlers more. I know. Or later stages. So there's a lot of fluctuation there. I think one of the things that I look for as a clinician is kind of ability to take in joy and kind of take in joy from some of those moments. Whereas moms that are really struggling really have difficulty, especially with that piece. So in thinking about navigating maternal guilt, I think culturally it tends to be portrayed as one or the other. And there's so many messages about what makes a bad mom and what moms need to do to be a good mom. And there's this really kind of portrayal of a zero-sum game. You're either a good mom and you're paying attention to your baby, or you're a bad mom and you're paying attention to yourself. And we see this across the internet, on the news. We see it reflected in so many different cultural portrayals, and sometimes even from feedback we get from our own families about what it's like to be a new mom. But we know from studies of women's mental health that it is not a zero-sum game, and that healthy babies need healthy moms, and healthy moms need adequate self-care. They need time to shower and to breathe and to sleep and to exercise and to take care of themselves in whatever ways are necessary for mental health. And ultimately, we're all in it for the long game, and our little ones need us to be healthy for the long game. And so self-care is a vital piece of that.
I love that. And I think that's the important piece, is how can we remember the long game and navigate that. Dr. Rohr, can you talk a little bit about what family members, friends, what signs and symptoms can they look for, and how do they respond when they either feel like their loved one might be struggling with postpartum, or like the example I gave, when we're kind of saying like, I feel like I'm struggling, like how can you actually support and encourage versus maybe sometimes shutting someone down?
I think that's such an important part of this. And I think the first step is, even before you get to the point of struggling, doing what you did, Liz, what I did with my second pregnancy, talking to your loved ones and making a plan in advance for both parties. He's not here. I'm sure this is okay to say. My husband had a little postpartum depression after our second. But we had talked from the very beginning about who are we comfortable reaching out to? Because with my first, it was like a friend came, she called my best friend, who called my like, it was this sort of frantic, like something's bad, something's wrong, she's not doing okay. And having that ahead of time, just like your birth plan, just like if you talk about how we're going to deal with behavior things and food, or we breastfeed, but have that be part of your plan. Like, this is I'm okay with you calling without telling me. This is what, if you start seeing this is when we need to get some help. And having like Dr. Netherton said, having your therapist, OB, whoever, be a part of that team. Again, we always go back to functioning, right? So if you're spending a lot of time dealing with, if you are seeing a loved one spending a lot of time dealing with these anxieties, these compensatory behaviors to try to manage them, if your partner keeps asking you to change the baby and it's not really explaining why, but just saying, I don't really feel comfortable, or I'm scared, or can you go check the baby because I think something's wrong, but I didn't see anything, but I can feel that something's wrong. So can you go check? So if you're starting to notice some of these kind of reassurance seeking behaviors, that's a time when maybe talking with your partner kind of gently about what you're noticing. I would always encourage not doing that in a heightened emotional state when you're flooded. You cannot kind of get into a discussion. It's not going to go anywhere. And having the partners have support as well. So we've talked kind of around the fact that men can develop postpartum depression, postpartum anxiety. What I'm seeing is that the prevalence rates are about half to 2/3 that of women. So it's not like an uncommon occurrence. So for men with postpartum depression, whereas we usually throw around 20% for women, it's about 10% for men. For men with like perinatal anxiety, I was seeing estimates of up to like 33%. And the strongest risk factor for men developing these is the woman's mental health. So if the woman is having difficulty kind of psychiatrically, then the man is going to have more problems. So being able to know a lot of time, not the man, it's not always the man, but the partner, but I'm speaking about a man because we do know kind of societally men's strongest social and emotional support is their female partner. So when we see these kind of dynamics happen where the woman is not able to function in that way, making sure that the man is not completely dependent on her for that from the beginning, that he does have his own support to access, that can be really helpful. But again, having partners supportive partners outside of the home, parents, friends, it's invaluable. I mean, it's just something you can't replace.
I love it. And go ahead, Dr. Nathan.
Oh, I was just going to say, I would also advocate for moms planning for more assistance than they need. And I think we really glorify this idea in celebrity culture and social media about, moms being able to do it all by themselves. And the question is not whether you're capable. The question is whether that is in your best interest, whether it serves you, whether you feel good doing it. And it is so important to have some backup ideas for how am I going to get some assistance so I can get some more sleep? How am I going to get some assistance with feeding? How am I going to get assistance so that I can take care of my own self-care? And be planning for that ahead of time, even if you feel like it might not be necessary. You can always weed that out, but it's very hard from a place of feeling crummy to kind of come up with a brand new game plan postpartum.
Yeah. And it's also like, it's interesting. I'm just going to piggyback on your societal comment of just how much feedback people feel like they should give a new mom and how many opinions exist. So I went to see my mom last week on Tuesday morning, and I had both the girls, and I was walking up the stairs at her. My parents own a business here in town at our tennis club, and she was in the restaurant, and one of the members that had been there I saw someone I had seen that had been there a long time, and I'm like carrying a newborn and juggling the 15-month-old, and I was like, I don't know how moms do this all the time. And it still takes me back for a second, because I made a comment of like, oh, guess they have help. And he goes, oh, but good moms don't, Liz. So you're doing a good job. And I was like, oh, wow, this really burns, because guess what? Like, I have a nanny because I do work full time. And like, I just had the morning off because I was with the kids, but I was going to work that afternoon. And it's just these little things that you hear that you're like, that really wasn't needed. And like, do you realize the impact that had on me of like, okay, so you're saying I'm not a good mom because I go to work, where like, I actually believe it's great, right? Like, everyone has their own, whatever works for you. And the reason I'm saying that is that I do think that sometimes we don't realize the impact of just little comments, right? So how's breastfeeding going? Well, why do we assume somebody's breastfeeding and that it's working for them, or that that's what they should be doing, or whatever it might be, where these things can really increase, right? Our guilt, our stigma, the shame, and it makes us feel a certain way because we're already feeling heightened, right? We're pretty sensitive in this period to begin with. And so how can we just be more supportive, be more open-minded? And this is actually a conversation, Chris, we have all the time about family members for individuals with OCD, not even in the perinatal period, right? But the individual with OCD knows what they're doing half the time is irrational and doesn't make sense. We don't need to remind them of that, right? Instead, we need to have this supportive stance of, how can I help you? How are you doing? And allow them to lead that conversation in way. And I want to hop into that, because I think it's really important for us to start to really talk for a second about the perinatal OCD period and how to differentiate. So one of the questions I get all the time, and so I wrote it down, is how would you differentiate between postpartum psychosis and postpartum OCD? And I get this question a lot because what Chris and I know is that sometimes, right, with OCD, it is irrational thoughts. And so it might be a thought about harming your child, and you might have this intrusive thought of, I'm going to hurt my child or do something wrong. But then with postpartum psychosis, you may also have someone may have similar thoughts. And so what would be some of the main differentiators, and how clinically, because a lot of clinicians do watch these talks, how clinically would you say, okay, this meets OCD criteria compared to postpartum psychosis criteria?
So I would get started with what the mom has to say about what she's worried about. When moms are struggling with perinatal postpartum OCD, moms describe very clearly these fears about what if I did something to hurt the baby, and it is a terrifying thought that moms go to great lengths to avoid, great lengths to try to prevent. Moms are having thoughts about dropping the baby, and they're avoiding picking the baby up, or these thoughts are so disturbing that they're coming in to seek care. Moms who are struggling with psychosis do not tend to have the same level of insight, don't tend to have insight about that process, do not experience these thoughts as ego dystonic or as frightening or as something that they are working actively to avoid. Often they're part of a more delusional process that feels like something that they are potentially wanting to do or thinking about doing. They're not identifying these symptoms as frightening, as disturbing, as upsetting, as symptoms to try to treat, as symptoms to mitigate against by doing things to try to keep the baby safe or to try to get rid of those symptoms or try to avoid.
Yeah, and that's at the very basic, that's the major. In postpartum psychosis, we often see that the thoughts are part of kind of a bigger delusion, like this child is actually not my child. There's the changeling kind of delusion that comes up a lot. Some religious delusions around, I need to hurt this child for us to get through. So it's kind of rather than an intrusive thought that's unwanted, undesired, needs to be avoided.
I wanted to ask, Sarah asked my question at 12:20 your time, Skyla. So I'm going to throw this. I was kind of talking to you at pre-live, Dr. Netherton, but I think one thing that I hear also from a lot of mothers about this period is they've been able to manage their OCD really, really well on medications, and as they go into the pregnancy process, they're really nervous about staying on medication, or if they go off medication and they do well, post-birth, right, then they start to have like an intrusive amount of like harm thoughts potentially, or you guys are just starting a good conversation, because a lot of my clients will say, like, people will make comments like the one that Liz heard, but then they'll be ruminating for hours. Am I a bad mom? Am I not good enough? Should I have never been a parent? So Sarah asked at 12:20, like, when do you recommend psychopharmacological assistance, or if somebody's already on it? So can you talk a little bit about is it safe to be on medications during this period? Is there, medications better than others? And is this something that people should do if the behavioral therapy isn't necessarily helping enough during this process?
Great question. So I would be really leery of being told by anybody that you cannot be on medication during the perinatal or postpartum period. I'm a psychiatrist that exclusively sees moms, and I work with moms all day, every day around medications during the perinatal and postpartum period. And what we're thinking about is how to weigh the risk of mom feeling crummy, feeling like heck during pregnancy or postpartum, and potential risks of medication. And any medication in pregnancy carries some potential risks, and those risks vary widely, and how likely we think they are and what the severity of those risks are. If I prescribed sugar during pregnancy, if I gave sugar cubes, as a treatment, that would carry potential risks during pregnancy. And so really we think about, what do we know about potential risks, and what do we know about, bless you, about the risks of moms feeling crummy, and how severe those symptoms are, and what ways they impact functioning and bonding and enjoyment. And we weigh that mom by mom. So it is not as simple as blanket statements, you can take anything in pregnancy. It's not as simple as you can take nothing in pregnancy. And it is not an all or nothing, not an all or nothing discussion. We work mom by mom to identify the best course of treatment in terms of medication. And often that best course of treatment is medication that mom has responded to in the past. We take that weigh that very highly. So If we know that mom has done well on Prozac in the past, and we are looking at whether mom needs medication going into pregnancy, we might really consider or strongly consider Prozac, not because we think that is the best medicine. There is no best medicine. The best medicine is what mom will do well with and what is going to help us mitigate that risk of mom feeling bad. And so I see the question about how often do I recommend pharmacological assistance? I would say very commonly, and it really depends on the severity of the symptoms, whether they are responding to therapy. And for severe symptoms, often we start therapy and med management concurrently.
And I want to say just very firmly, because Dr. Netherton is much more diplomatic than me, but it is absolutely the case that there is plenty of research suggesting the safety of certain medications that are very helpful in the perinatal and postpartum period and for breastfeeding. And it is also absolutely the case that there are many practitioners who don't know that, who aren't as up to date on that research. And so again, that's why it's so important to come to things like this, to learn and to learn how to advocate. I took Lexapro during my second pregnancy towards the tail end of it to get ahead of the postpartum. And same, Liz, my experience postpartum was so different from my first that I also had a lot of that guilt, but I'm really grateful for it. I'm really grateful for it.
Yeah. And the thing I want to say too is, we see this in individuals with OCD without not in the perinatal period, that medication in and of itself may be a trigger. Even if you know you want to take it, it may be triggering to take it for different reasons, and that could be OCD driven. And so if that's the case, this is where I want to talk about the next piece of treatment, which is that integration of behavioral therapy as well, right? None of us are saying that we're going to want to encourage you to do medication only, right? We're going to want medication and a behavioral intervention. And so if you're finding that OCD is latching on to you taking medication, where if you didn't have OCD, you would want to, or you'd consider it, we want to work on that. But also in general, right, for any of your OCD symptoms, medication alone isn't the treatment for OCD. We're going to want to do it in conjunction and combination with ERP. And so let's talk about that for a second, Chris and others, is what do you know about treatment during the perinatal period from a behavioral health standpoint? And Chris, one of the things I'm curious and I want us to talk about as OCD specialists is, does it change? And have you seen there be a shift when you're working with a patient in the perinatal period compared to not for their OCD symptoms? What are your thoughts, Chris?
Yeah, no, I didn't know if you wanted it for me or for them. I kind of thinking, being the male on the panel, I mean, I know I just think of clients when we're doing these streams, and I know one of my clients, it was like his wife doesn't have OCD at all. He does, and he was in a really good recovery period. In fact, we hadn't worked together in 7 years, and he came back just roaring and was like, we just had our first child. I am so afraid of everything I do is going to harm the baby. I was putting on cologne in the house, and I'm like, is the baby going to inhale this? And then it's going to make him sick, and the lungs won't develop and all this stuff. And so I think one thing that I've kind of been taking from this talk is we are such in healthcare, we're such a react healthcare system. We don't go in like Liz. I love that you already had that plan probably because of what you do for a living. But I think for most people, they don't. And then they jump in after. When I'm working with a client with perinatal OCD, whether it's the husband, whether it's the person with, I mean, one thing that I like to do is really kind of get them back to sort of, I like values work, because I think what happens is the OCD feels different. This is at least what I hear from my clients. The OCD feels different because before it's like, okay, it was me or it was these other people, but now I'm responsible for this little child and I don't want to do any treatment. I don't want to have to put potential risk. And there's a lot less willingness to take any risk, or there's a lot less willingness to live with uncertainty because they're like, this is real, this is going to affect my child. So I think the thought when Liz asked that question is, I think I'm a little softer, and maybe that's just my own stuff, wanting to make sure that we're really working on values work. And you're saying that about the medication, balancing how this medication is going to help. And I think that's what I really work on with the clients is you're not going to be, the fear is if I do treatment, all this stuff, but it's you're not going to be able to be present with your child. And you're not going to be really able to lean in if the OCD is driving this big wedge. So using that as the why, using values work and saying, look, you're not able to be the mom you want to be or the father you want to be because the OCD is having you disengage and do all these rituals. And as we know, it's really hard to be present. So I guess to answer your question, Liz, I think it's the same. I don't have a different treatment protocol.
Yeah.
Except I think the buy-in is the bigger thing that I think is a block. A lot of times the parents, or we were talking about prior, about, people doing residential. I know one thing I've heard from a lot of moms is like, I don't want to do treatment because now I'm going to be in the session. I'm being selfish. I'm not spending an hour with my child, or if it's an intensive or that. And so one thing I'll talk to the parents is like, spending this time right now is going to let you be such a better parent and be present.
That's right.
So taking care of yourself is so important. So maybe the buy-in and a little softer and values work is the first things that come to mind.
Dr. Rohr, do you have anything to add?
I just agree. Lizzie, you and I talked about, I remember talking about it, I think a year ago, about some of just kind of anecdotally having some trouble getting buy-in on doing the exposures to these intrusive thoughts and to these experiences that felt, again, that the stakes were so high. I would rather live with the distress than risk that my baby is dead in the other room, or I would rather live with the distress than risk actually. And so even thinking through and doing the kind of imaginal pieces were so intolerable, but that just means they're, I think, a little bit more psychoeducation on the front end. So even people who are really good at dismissing those intrusive thoughts, like, the holes are going to come through my windshield when I'm riding behind the truck. Oh, that's a silly thought. When it's about the child, it becomes so much more difficult to just label that as such and say that's the OCD talking. That's actually not what I want. And so I think, Liz, you and I talked about this idea of using ACT for OCD versus ERP, and kind of settled on, again, ACT values work to build the buy-in, build the rapport, build the connection, and then, getting into ERP, because it still is. It's the gold standard. It's still what works.
Totally. Go ahead, Dr. Netherton.
I was just going to add in that I think it's also important to look at where mom is getting information outside of the clinician client relationship, because I think that moms tend to get a lot of information culturally that good moms check and check again. A good mom would is kind of a common idea, and we get those ideas from all kinds of places, and it's important to investigate that as well.
Yeah, it really is. And two things I'll say. So the first is that when we think about values-based work, right, we're thinking about how can we make sure our values are, that we can live by our values, right? But again, for those of us with OCD, that's also what trips us up, is because OCD attaches to our values. So there's this piece of like, I want to live by my values, but also this is why I'm doing these rituals, is because this feels so against my values. This is about my kids. This is about my loved one. This is about my faith, whatever it might be. And Jeff Szymanski and I were just talking for half an hour before this about interventions and treatment. And what we were saying is, like, when you think about exposures for ERP, some people might say, well, I don't know that you have to do exposures. There is not a way for a patient with OCD to live their life without doing exposures. So even if we're not, right, like even if you're not intentionally doing an exposure, say you're dealing with postpartum harm stuff around your kids, you might not intentionally sit down and do a script, but being with your kids, being an active parent, life is the exposure, right? And so either way, as Chris is saying, like, we have to address the rituals, and we have to address you getting back into living life, not avoiding, right? And so when you think about it, in the perinatal period, there's this huge motivator. It's a little living being, right? That pushes you, and kids are germ balls, and they're great exposures if you have contamination or different OCD, right? You really can't control a child the way you might be able to control your own actions. And so anyway, I want to just push that, the piece I want to come back to is that treatment works even in the perinatal period. ERP doesn't really look that different, actually, right? As Chris is saying, we might do things slower. And of course, we might be taking a more eclectic approach, in the sense that we're also going to be talking about hormonal shifts and other changes and how you're feeling in general, and depression. We might have that talk a little bit more than we would with just a standard OCD case that isn't in the perinatal period, because we don't want to ignore the life transitions and stuff that's happening. But the OCD treatment in and of itself, medication might be different because you're in the perinatal period, but you still might consider medication. ERP might look a little bit different as far as how we do it, but we still should be doing it. And so treatment looks very similar. And I have not read any studies. I don't know, Dr. Rohr, if you or others have. I haven't read any studies that would show that ERP outcomes change during the perinatal period. I believe they're still just as effective.
They're quite effective. And that's, you mentioned at the very beginning, some practitioners might want to focus more on the childbirth or the baby. And my immediate thought, Elizabeth and I had an experience with an unnamed practitioner who had some pretty outdated ideas about where postpartum OCD came from. And I think it's important. It can actually it can exacerbate symptoms to spend that time, because it implies that the thoughts are significant, which they're not.
Yeah. And so desired, and that we can just undo them, right? That we can just talk our way or think our way out of them.
Yeah. And so focusing on the experience of the thoughts rather than the content, and just going through the ERP as you would otherwise is really what you can do. And so I guess I would say seek out an ERP practitioner rather than like a motherhood specialist, because you just don't, I think it's a better idea.
Please find an ERP specialist if you're struggling with OCD.
Yes.
I think additionally too, as clinicians, like we're the ones sometimes that I think what makes it different than, you know, all my friends that I always talk to that do other types of therapy, I think the biggest difference is sometimes like the client's looking at us to guide. So if we're going in there and we're like, okay, you can't do that exposure around your child, that would be so scary and dangerous. I mean, then of course the client with OCD is going to be like, you're right, let's get out of here. But, you know, the client that I was talking to, the father, you know, I was really telling him, I'm like, this is no different than the work we did 7 years ago. It's not. Like the OCD, I wish OCD was a person so I could just like punch it, because I hate how insidious it is. I mean, it really uses your child almost as like a hostage. Like, oh, you're going to take that risk and not check for a 58th time that your kid's breathing? Well, I guess you're going to be okay with a child that's dead. And what I felt with my own OCD experience is like, my OCD didn't listen to language. I almost felt like OCD spoke a different language. It learned through my rational brain learned through observation, through behavior, and through change. And so when I'm working with a client, I always tell them, I'm like, I know it's so scary. Like I'm working with a client who's a new mother, and I'm like, I know it's scary to not like set 15-minute alarms to wake up. But one thing that I always address is like, you're exhausted because you're waking up every 15 minutes to check your child, which if anything, we have facts that's more dangerous than, you know, you've already set up, you know, you've already seeked out way too much reassurance how your child should be sleeping. But that 15 minutes, I can guarantee that lack of sleep is going to cause way more problems and discomfort with your child, you know, experience. And so I think it's really our job as clinicians to make sure they know. I think sometimes people think like, oh, ERP should be different at different stages. It's all the same. The buy-in might be different, or, you know, if somebody has co-occurring trauma with their, you know, with the symptoms, you might have to go a little bit softer. But at the end of the day, the ERP is going to help the client recognize that what they're doing is solely because of fear and not because it's in the best interest of the child.
That's right. And the one thing I'll add in as well, Chris, is for everyone to remember, it's no different than other subtypes. So if you think about being afraid of COVID, right? If OCD has latched on to COVID, we are not encouraging you to go take high risk, right? We're asking you to do things everyone else does and to follow appropriate guidelines. It's the same in the perinatal period. No one's saying, don't care about your baby, don't ever check on them, right? No one is saying that, because like that wouldn't make sense, right? But it's what is within reason. And I actually struggle a lot with this, because we know that sometimes when there is something that you know might be wrong, you might go to doctors and they'll say things like, oh, you're just a new mom, or that's just normal. And you're like, no, this isn't normal. I remember dealing with this with Olivia. I kept saying like, I've been around a ton of kids, something is wrong. Like I need help. And turns out she had a dairy allergy and acid reflux. And we had to wait until she was literally pooping blood before we would come up with an intervention. When as a parent, I was like, there's something wrong. Like a child does not scream in pain like this and refuse bottles. Like I'm doing exposure therapy around bottles with a 2-month-old. There's something going on here. But again, how do you have that fine line of like, in the back of my head was like, is this my OCD? Is this my anxiety? Like, am I overthinking it? When I knew as a mom, like, no, this is legitimate. And so again, I want to push you guys. I always say this and people are always like, well, Liz, I'm not sure. You know, typically when it's OCD versus not. Right? If it feels urgent, if it's to appease anxiety, if it's these like intrusive thoughts versus when you're like, no, I'm genuinely wanting to know this. And so again, there's going to be a lot of things as a first-time mom, a lot of reassurance you get that's totally normal, right? Or questions you ask a doctor that are totally normal and valid. But there's also going to be some you have the urge to do or not do, or to even justify, because like it makes sense. I'm a new mom, where you know it's more OCD. And remember, OCD isn't appeased at one answer, right? So it's kind of like, oh yeah, I'm going out of town, I'm going to check that lock once. OCD doesn't feel good after the one check, where someone without OCD might feel good. It's the same in the perinatal period. And so ERP is kind of done as normal, though it may be tapered a little bit differently. All right, so final thoughts and wrap up. We'll start with you, Dr. Rohr.
Yeah, I mean, just kind of tying together that and some of the guilt that we were talking about earlier, the experience of motherhood and parenthood comes with a new onset kind of basic grief and fear that is just sort of gonna be there. There is this terror that terror is maybe it, but that I talk with parents about the fact that you have this thing that you've never felt this way about, and it's just over there somewhere. And that's a very new experience. And so there is this sense of that you will not get to a point of no anxiety. It is just you're going to have to tolerate that experience as a parent. And that there's a lot of the guilt, and Liz was smiling because this is like my big thing, but a lot of the guilt that we feel, I think, could be better characterized as grief. Like, I have some grief that I cannot spend the time that with this child that I spent with that child. And it is a different path because we have 2 kids now. And I have some grief that in order for me to have my needs met, I have to do things that don't seem to be in line with what I'm supposed to do. And so I think that can be really helpful to sort of recharacterize it as this is just, there's some hard parts of it that can make us grieve and that of course, then we want to fix it. So it makes us feel guilty. But when we then can't get out of these experiences of these intrusive thoughts, there are resources available to be able to help with that. So some of this is what we learn to tolerate, and some of it is what we need to be able to address.
I would just highlight the importance of seeking care from someone with experience in evidence-based therapy for OCD, and from prescribers who have experience working with pregnant and postpartum moms.
Liz, you're mute.
There we go. Chris, we'll hop to you for the end, but we'll just reemphasize, and I know, Chris, we always do, is just no matter what, we want specialty OCD providers, right? So even as Dr. Netherton is here, you see there are psychiatrists who specialize in anxiety, OCD, depression during the perinatal period. There are clinicians like Dr. Rohr and others who specialize in this arena. And so it is possible to find both behavioral and psychiatric care with individuals who specialize in this treatment, because what we know is that without evidence-based treatments, you're not going to get the outcomes you deserve. Chris?
Yeah, my final thoughts is kind of to answer what Patricia asked is like, I think the biggest thing that I tell all clients that have a lot of fear around having children because of OCD is like, please don't let that be a factor. As you saw in this panel today, there's research coming out, there's specialists like Liz was just talking about. So never let the OCD, whether it's the fear of perinatal OCD, whether it's the fear of passing it on, please don't let that be a deciding factor in not having children. I think we give up too much for this disorder. So please don't. If you want to have a family, do it.
In fact, that'll push you to do treatment even more. So we'll end today. Thank you so much, Dr. Netherton, Dr. Rohr, as always. This is amazing. I think we could go on. It just goes to show for like 3 hours, just talking about the differences and how to treat. And so we can get more specific and do many more of these. But thank you both for your time. And more importantly, thank you for what you do and for your work in this field, because it is so needed. And all the moms and others in the perinatal period out there are grateful for you. As always, remember, it doesn't matter what period, what stage of life you're in, help and hope are always available.
Bye, everyone.
Bye.